I can perfectly.
You can or you can't? You can hear
I
me?
can, yes.
Okay, great. Hi. So like Lee said, I'm Dr. Barbara Stricker, and I'm here with my partner, Dr. Ralph Philosophe. Yep, see him waving over there. And as she said, we're both female pelvic medicine and reproductive surgeons. And we work at Sturdy Center for Pelvic Surgery and Bladder Health. And we have offices both in Plainville and in Attleboro. So what do we do at the center? Let me see if mine, okay, Lee, I'm having already problems. It's not churning. Do you want to do the slide?
Can you use the your arrow key in the bottom? Just push the right arrow key.
Yeah, that's what I was doing. Okay, actually, if I figured out how to do it. Thanks.
Perfect.
Okay, so what does the Sturdy Center do? So this slide is a very busy slide, just to kind of talk a little bit about what we do at the Sturdy Center. Today, we're going to really concentrate on that bottom left section, bladder problems, and we're going to talk about that. But just so you know, we also treat pelvic organ prolapse, and that's when patients come in feeling like everything is dropping out of their vagina, and their bladder could be dropping, or their rectum, or the top of their vagina, and we have surgical and non-surgical management for that. We also treat all different types of abnormal bleeding and pain. Fecal symptoms, we're going to talk a little bit later, but mostly I'm concentrating on bladder symptoms today, and we'll talk about all of this in a little bit more detail. So I like this slide, and because it's true of many of us, especially many of us that are here right now. And it says, with age comes skills. It's called multitasking, and you can cough, laugh, sneeze, and pee all at the same time. And so that's going to be part of the subject we're talking about today. Okay, I guess one of the main things that I want to get across today is that incontinence is not a reason to be embarrassed. Many people don't tell me that they're incontinent, don't tell me about their bladder problems. One of the things that I do on every patient who walks in is ask them about bladder problems, because so many people won't even talk about it if I don't ask. It's shocking almost to hear how many people are affected. 43 million Americans are affected by incontinence problems or bladder problems. And if you think the US has, I don't know, like 320 million people, that's a large proportion of the population have issues with incontinence. 1/3 to 1/2 of all adults over 60. So I guess we're going to see later what is the age of the group that's here, but that might be many of us have problems with overactive bladder or incontinence. Overactive bladder, we're going to talk about more, but it's when you come in with symptoms of either urgency, frequency, getting up at night, running to the bathroom. So almost half of us have issues with that. And as I said, 50% of people won't talk about it with their doctor. So if we don't bring it up, they don't even bring it up to us. And this slide kind of says just what the last one did. It's things that people come in with. I'm afraid to leave my house. I won't go on long car rides because I'm embarrassed that I might need to get pulled. I might have to pull everybody over. I don't want to go visit my friends, sleep over my children's house. How can I ever go on a date or get a job when I have to run out so much? So these issues really affect patients' quality of life, and something that we are trying to help. So what this slide shows also is really interesting. So this is a little old slide, so the numbers aren't exact anymore, but the proportions are. And what this does is it talks about the frequency of many common diseases that we see and we wouldn't be embarrassed to talk about, such as asthma or diabetes or osteoporosis, and it puts in comparison patients with bladder symptoms. So if we just even look at patients with overactive bladder, those are that frequency and urgency and running to the bathroom. It's much more common than asthma or diabetes, and yet patients feel very comfortable coming in and talking to us about that. Also really interesting is fecal incontinence, which is something very distressing to patients that it's really hard to get them to talk about. Also, really even more common than osteoporosis or Alzheimer's disease, but it's something we really got to keep asking because so many people are embarrassed to talk about it. So what is bladder health? What do we do at the Sturdy Center? And it's a way to live your life without worrying about the bathroom and having to run, lose urine, or retain urine. So here, let's talk about some common myths. Okay, so incontinence is a part of normal aging. And actually, it's common, but that doesn't mean it's normal. And that doesn't mean that there's not many things we can do to try to alleviate, help, or even cure it. Nothing can be done for incontinence. That's a very common misconception. And many patients don't tell me about it because they just don't think we can do anything about it. They've talked to their doctors in the past and told them about it, And because those doctors weren't specialists, they kind of ignored it or just brushed it off. So they just kind of assumed there was nothing they can do. But most incontinence can be cured or at least really helped. Also, a lot of people don't talk about it because they're worried they don't want to have surgery. And surgery is one way to treat some of the issues that people have with their bladder, but there are other conservative therapies that work very well. All right, so the first thing I like to do when patients come in is talk a little bit about the difference between the main two types of incontinence that patients can have. So there are many different types of incontinence, but most of it is either stress-related or urge-related. So what I'll do is I'll draw this little bladder. I'll point out this little bladder and urethra so you can see the pictures on the screen. And I don't have a pointer here, but that circle on the top is your bladder, which acts like a balloon that fills up with urine. And then it comes out your urethra where you urinate from, where you pee from. I want to explain the difference because I'll say to patients, it's the way we treat it is really different. So it's sort of like when patients come in and they can't see well. So they go to an ophthalmologist and they can't see. It could be due to cataracts or it could be due to being nearsighted. And that's important for the doctor to figure out because if it's cataracts, that would require surgery. And if they're nearsighted, that would require glasses. So patients come in with, I can't see, and then we kind of figure out what it is so we know how best to treat them. Same thing with bladder problems. Patients come in and say, I'm losing my urine or I'm really unhappy with my bladder. And we really try to tease it out and figure out, do people have one or either of these, or many people have both because they're both so common. So the difference is stress-related issues or problems with urethra or the ligaments and the muscles around the urethra, where urge-related symptoms are problems with the bladder. So with stress-related symptoms, the urethra is not tight enough or the ligaments around it aren't tight enough. So when you cough, sneeze, lift, laugh, you put pressure on your bladder, but that urethra is not tight enough and you leak. Urge is different. That's due to a bladder problem. And what happens is the bladder spasms. So when the bladder spasms, it doesn't hurt like other muscles that spasm. It feels like I got to go. So if you have a spasmy bladder, you're feeling like I have to go. So let's talk about that in a little bit more detail. So first, we're going to look at stress related. So here's just another picture of a bladder and a urethra. And you can see with that increased pressure, that blue arrow, coughing, sneezing, jumping. You'd be surprised how many women going on trampolines, whatever puts pressure on that bladder. The urethra is not strong enough or the surrounding structures aren't strong enough and you lose your urine. Urge is different. Like I said, urge is a bladder issue, not a urethra issue. So the bladder will spasm. And when it spasms, it feels like I have to go. So the symptoms people have a frequency, because I have to go. Urgency, a bigger contraction, I got to go right now. A really even bigger one, urge-related incontinence. So they're like, oh my God, I got to go. And then it starts to come out. Or nighttime, it wakes you from sleep because it's spasming and telling you got to get up to pee. So there are different triggers. We talked a little bit about the stress incontinence triggers of coughing, sneezing, jumping up and down. The triggers for the bladder spasm are different. So the most common trigger is volume. So where it used to be, you can fill your bladder all the way up to 300 cc's or 400 cc's before your bladder started to spasm and tell you have to go. When you have this jumpy bladder, you can just get up to 100 and all of a sudden your bladder's saying, I gotta go, I gotta go. So we tell patients they have a small bladder. They don't really have a small bladder. Their bladder is the same size as everybody else, but it feels like it's small because the second it starts to fill up and you get to around 100, your bladder's starting to spasm and telling you have to go. So you're running to the bathroom more frequently. Other really common ones, running water. I'm fine until I'm doing the dishes at night, or I brush my teeth in the morning, or I step into the shower and all of a sudden I start to lose urine. Those are really common complaints of people with urgency and urge-related issues. Key in the lock, I'm fine, I'm driving up my driveway. I'm just about to go in the bathroom. I see the toilet, I can't pull my pants down quick enough. Another really common one actually is after you urinate, oftentimes your bladder will spasm. So people will say, I sit down, I pee, I get up and I got to go right away. And these are all really common symptoms of overactive bladder. All right, let's see. We did this already. Let me fill this in. We talked about the triggers. And these are just all the common complaints. Like I said, I mean, people can't go for car rides. They know where every bathroom is in the mall. My life revolved around bathrooms. They're exhausted here. Let's go back one. I'm exhausted because I'm up all night going to the bathroom. So these are, when you get people talking, these are the things I'm sure a lot of you can relate to a lot of these. So when patients come in, we want to kind of figure out, what are they having? Urge symptoms? Are they having stress symptoms? Are they having both? And so we come in and we kind of assess them. The most important thing we do is get a history. So much of it is talking to each patient and finding out what exactly their symptoms are, how long has it been going on, how does it affect their quality of life. Physical exam is also important because there are things on an exam that we can see, that we can correct, like being too dry, atrophy of the vagina, real common problem that we can fix, or prolapse. So we call, earlier I talked about them kind of being separate, but they play into each other a bit. People with prolapse are more likely to have a lot of these problems. So we'd want to see that so we can talk about it. We also like when patients come in with avoiding diary. So if you're going to go to us or your doctor with this, over the next, spend around 3 days just paying attention to what your symptoms are. Writing down, do I really go every half an hour, or does it just feel like I'm going every half an hour? Write down how often you're going to the bathroom. Figure out how many times am I really getting up at night? Feels like it's a lot, but how many times is it really? So write down, when I leak, what's coming beforehand? Do I cough first, or is it, oh my God, I gotta go? Or nothing? Do I just start to leak with nothing before? So think about all those things, because they'll be really helpful for your doctor or your nurse practitioner when you come in. In terms of testing, really, there's not that much we need to do. The 2 tests that we do on almost everybody is a urine analysis and a post-void residual. So a urine analysis is when you pee in a cup and we kind of figure out if you have an infection, because that would be very important to treat. And we also want to see if you have any blood in your urine, because sometimes things like cancer or polyps, other types of problems in your bladder would show up with some blood in your urine. So those are really the main 2 tests that we do on almost everybody who comes on in. Urodynamics is a more specialized test that most people don't need. If you have a more tricky problem, you have lots of different complaints and we can't figure it out, you've had previous surgery, you're diabetic. So sometimes we'd want to do a special test of the pressures in your bladder when it fills and when you void. Again, that's not done on every patient, but something we have if we need. And one of the main things we like doing is trying to meet patients so we can figure out reversible causes, because it would be great if you had a reversible cause that we could fix really easily. So we'll go over some of these issues. So for instance, recurrent urinary tract infections, there's lots we can do about that. So we'd want to try to assess, that's why we get a UA and try to assess previous cultures. Diabetes, a lot of times just getting better control of your blood sugars is very helpful for getting people more on track so that they're not leaking urine. We also go over a list of all your medications, because a lot of medications can cause bladder issues. Sometimes you can't go off those medications, but other times, we can exchange one med for another, and that might really help what's going on with your bladder. Too much, everybody knows about too much fluid causing bladder issues, but too little fluid can also. When you're dehydrated, your urine gets really concentrated and irritates your bladder. So a lot of people just don't drink all day because they're so worried about leaking or having to find bathrooms. So that can make things a lot worse. So we talk a lot about fluid balance. Fluid retention, also an issue. So that is an issue at all times, but really mostly at night. And we'll tell people, a lot of people have some swelling in their legs, and especially towards the end of the day. And so when they go to sleep, they put their feet up and all that fluid from their legs drains back into their body. And so they have that big fluid load and they're up all night, peeing. So ways to get rid of the swelling in people's legs really help that nighttime sleeping. So we have a whole bunch of tricks to try to do that, to get your legs to look, we say, well, we want your legs to look at night the way they do in the morning. Constipation, also a really common reason why people have problems with their bladder. Again, something a little easier to treat. When we treat the constipation, many people's bladder gets much better. And for other people, just difficulty ambulating is an issue. So it's not as much that they have the urgency, it's that if they had more time, they'd be able to get to the bathroom. But because they might need a walker or a cane, It's difficult to get out of bed in the middle of the night. They can't get to the bathroom quick enough. So a lot of the treatments we talk about increase the amount of time from that urge to when people go to the bathroom. So if we can just extend that time a little bit, then they have time to go to the bathroom. Or we can do things like putting a commode, suggesting putting a commode right by your bed. So you don't have to run all the way to the bathroom. You could just kind of turn around and have the bathroom there. So there's all different ways that we kind of deal with each patient, get a good history, and figure out easy ways that we can help people. Okay, next. So the next and the biggest bulk of this lecture is going to talk a lot about treatment of incontinence and treatment of bladder symptoms that a lot of you are having. So I'm going to start first with all the urge-related stuff and stress-related stuff. So just to refresh your memory, the urge-related stuff is when your bladder spasms. So it's spasming and it's saying, I gotta go. So you're gonna have frequency, urgency, leakage, and getting up at night. So let's talk about ways to relax the spasm in your bladder. So these are all the things that we have in our toolbox to try to help patients. And we're gonna go through each of them a little bit. We'll talk about each specific patient a little bit more, what would be best for them. But these are the types of things that we do to try to treat it. So we have lifestyle modification that I'll talk about in a minute, physical therapy, different types of medications. Then we have these two treatments in the red and the purple box, which are kind of cool treatments that work on the nerves of your body. So neuromodulation has been around for a while now. Works in all different parts of medicine. So from deep brain stimulators for Parkinson's disease, pacemakers for your heart, pacemakers for pain, pacemakers for your bladder. So there are all new ways that we try to stimulate the nerves to get different parts of your body to work better. And both the tibial nerve we'll talk about in the red and the purple interstim or sacral nerve stimulation are two really great ways that we help patients with their bladder. And lastly, Botox. Botox works on the muscle. And we'll talk about that a little bit more too. Okay, so first one, lifestyle modification. So we begin with this with almost everybody. So many people have done this already with their primary cares, but if not, we talk about this with most patients. So something like weight reduction, which I know is a lot easier said than done. All of us who have tried to diet know that it is not always so easy, but weight reduction is really helpful for bladder symptoms. If you lose just 8% of your body weight, it decreases your urinary symptoms by 50%. So for a 170-pound person, if they lose 13 pounds, their symptoms get much better. And again, I know that's easier said than done, but that's something we see a lot. Patients will come in after just a good diet and exercise or a bariatric surgery or the new medications like Ozempic. And they're like, wow, doc, I'm just so much better. So weight reduction is a real nice, has other benefits as well. So something we talk about with everybody. Also, there are a lot of bladder irritants. So smoking, cigarettes, like we said before, proper fluid intake. So when you're dehydrated, that concentrated urine is a real irritant. So a lot of people have that problem without realizing it because they're limiting their fluids. Or things that we know about like caffeine. I'm saying while I'm drinking my coffee this morning, but caffeine, alcohol, spicy foods, acidic foods. So we go over with everybody what they're really taking in, things that might be irritating their bladder, talking about, ways they can try to help that. Some people want their coffee anyway, and that's okay, as long as they realize what's going on, then that's a choice they make. We also talk about different ways to train your bladder to increase the amount of time between voids. So for instance, we'll have people take right on their pad how often they're peeing. So if they see they're peeing every hour, we then say, let's see if we can wait for an hour and 15 minutes. And so they try that, and they slowly, when they're good with that, we can kind of increase the time a little bit more. We also talk about things like urge suppression techniques. So when you feel that, oh my God, I gotta go, ways to do a Kegel exercise, and we teach you how to do that to try to suppress that urge. So you have time to kind of suppress and walk slowly to the bathroom, and you're not running while you're leaking. Schedule voiding and time voids are really similar, but those are for people who don't really sense the need to void. So we'll see patients like that too, and we'll talk about that more a little bit later, where they don't even feel the need to void, they'll just empty. And so having those people, when we write it down, a lot of times it's, well, that happens when I'm at 3 hours. But if you kind of set your clock for 2.5 and you go to the bathroom every 2.5, that won't happen. So everybody's a little different, and we kind of need to get a history from everybody and figure out ways that we can help them. Also, some medications you have to take. Some people have to take diuretics. But we can talk about, ways of taking them that are not as painful. So for instance, if you take a diuretic in the morning, when you're just trying to get out of the house, you can't run any of your errands because you have to go to the bathroom so badly. And that's when most people take their diuretics. Sometimes if we do something simple, like change your diuretic to 3 o'clock in the afternoon, this way you can in the morning get all your chores done. When you're coming home to make dinner at 3 o'clock, you take your diuretic then. People don't mind urinating a lot, when they're already home and they're making dinner and about to have dinner. That also offloads, gets rid of all of that fluid. So when you go to bed, you've gotten rid of all that fluid in your legs and you're able to sleep more through the night. So just little simple changes like that. And again, we go through each patient, what's going on with them, trying to figure out best ways that we can help everybody. And I like this. This is actually a Dr. Philosophe slide he gave me. And it says, my doctor said only 1 glass of alcohol a day, and I can live with that. It's a very cute, funny slide. Okay, so next, physical therapy. So physical therapy is something we do at our center, but there are other centers. You need to go to a special physical therapy center that specializes in pelvic floor therapy. But the point of it is to relax the spasm of, your bladder's a muscle. So you want to relax the spasm around it. And many people get much better with it. It's typically once a week for 8 to 12 weeks. And again, either with us or, we can recommend places near where people live. It's not going to really help people with very significant incontinence. So with people that are in many pull-ups a day, we don't even recommend this. But for many people that with lesser degrees of urinary symptoms, physical therapy is very helpful. And it's a combination of exercise and electrical stimulation. So the exercises are similar to Kegels, but we kind of teach you how to do it. And so it's a biofeedback where we kind of measure how you're using your muscles, making sure you're doing it the right way, both contracting and relaxing. And we also do something called electrical stimulation, or e-stim. And this is, people who've had physical therapy in other parts of their body know about this. If any muscle's in spasm, you put a little electrical impulse to it, it gets it to break. And so the bladder's a muscle. So it's something we do with that too. So it feels like a little buzzing. It doesn't hurt, but we stimulate that muscle trying to get it to relax. Okay, let's move on to medications. So I think all of us have seen many commercials or have been on many of these different medications. Names, just because you might have been on them: Oxytrol, Sanctura, Vesicare, Enablex, Ditropan. These are all very common medicine. We'll see commercials of, I gotta go, I gotta go, I gotta go, or women being led around by their bladders. Lots of commercials because it makes lots of money for these companies, because as we said, there are lots of people who have these issues. The newer medications, Myrbetriq and Gemtesa, are now out, and they're not any better than the older medications. They work just as well, but they have a lot less side effects. So, and we're finally getting insurances to cover some of them. So they're a really nice option for people who've had a lot of side effects from the other medications. So the nice thing about medications is they're easy. People like using them. Pop a pill every day. And for some, they work very well. 70% of people really see a significant difference when they're on medication. Cons about medications are some of them are expensive, especially the newer ones. Some of the ones with less side effects, it depends on your insurance. Though again, I've been lucky lately. I'm seeing a lot more people being covered for some of the newer medications. Also, you use it indefinitely. Not such a bad thing, but some people don't like that. It's sort of like medicine for your blood pressure. Your blood pressure is not going to go away because you went on medicine after a certain amount of time. You're just on this the way you're on your thyroid medicine. Just going to be on it, basically forever. And again, some side effects, much less with the newer medicine. So a lot of people get better, but at least in the older studies with the older medicines, but by a year, many people stopped using it. And it's for a variety of reasons: expense, stopped working as well, side effects, big reason. I haven't seen yet, and Dr. Philosophe, you can tell me, but if you know of any, but I haven't seen any data yet on the newer medicines and what the discontinuation rates are at a year. But I'm going to assume when that data comes out, it's going to be a lot less because there's less side effects. So people will probably be able to stay on it somewhat longer.
The newer medication, I think the blood pressure is the issue. I'm just got to be careful with people with high blood pressure on the newer medication.
Some tests, not as much, but yeah. This slide just says the same thing, so I'm going to let that go. Okay, so now I'm going to talk about neuromodulation a little bit. So the two types of neuromodulation we have are peripheral tibial nerve stimulation, big terms, but I'll explain it more, and interstim, which is a bladder pacemaker. So we'll talk about both of those. So peripheral nerve stimulation, it's such a nice little procedure. People come in, they sit down for a half an hour, and one of our very nice nurses in our office, it's Trish, puts a little thin needle. I like to call it like an acupuncture needle. It's not really acupuncture, but people know not to be afraid of that because it's so thin. So it's this very thin little needle you put in the ankle, you push a button, it stimulates a nerve to stimulate a nerve to get your bladder to relax. And people come in once a week for around 12 weeks, and then that gets extended, and most people come in once a month. So I'll talk to people about this and medications because they both have similar efficacy. And you'll have lots of people say, who wants to go in? I'm just going to take a pill. That's easier. I just want to take a pill every day and that's it. And then you'll have other people say, who wants to take a pill or I can get side effects. So, I don't want to take a pill every day. I'd rather come in here eventually once a month, get plugged in for a half an hour and leave because efficacy rates are similar. So a lot of this is really just patient preference. And this slide just shows, one of the brands, Medtronic brand of, you can see that little ankle there of putting that little thin needle. And again, many patients love this. We get phone calls with people who move to the area from other areas. Oh, you're a tibial nerve center. Great. I need to, I want to come in for my once monthly treatment. And again, it's pretty effective. It's as effective as medication. And most insurances cover it. Okay, so now we get to the big guns. So interstim and Botox have really changed the way we treat bladder patients. I always make a joke. I never get more hugs than from my interstim or my Botox patients. This has really revolutionized, changed the care of women who previously were in pull-ups and diapers and multiple pads a day and stuck at home. These two things work very well for even patients with really significant issues. And let me just skip and I'll go back. So let's talk about interstim. What's interstim? So interstim, like we talked about before, we talked about neuromodulation and how it's being used all over, deep brain stimulators for Parkinson's, pacemakers for your heart. This is like a pacemaker for your bladder. And so what it is a little device, and you can see those hands above, they're showing the little batteries and the size of them. These little batteries we put right under the skin on the buttocks, that little fat cheek we all have over there. So it's hidden under, underneath your buttocks, so you don't see it. And a little wire that lays next to the nerve that innervates your bladder. What I like about this therapy is you get to try it before you buy it. So what patients do is they come either into the office or into the hospital, and that's patient preference. I'll talk to them, about the pros and cons for both. And we take a really thin wire and we put it in the side of your back. People kind of get freaked out. Oh, it's in my spine. It's not in your spine. It's on the side of your back. And we lay it next to the nerve that innervates your bladder. So it's not in the spine. It's once the nerve has already come out, and we lay it next to it, and we send them home with a little battery pack that they're wearing for the test, on their hip. I'll show you a picture of that in a minute. And we just wait. Do they like it? And they wait a couple of days to the most a couple of weeks. And many, many people, this is, again, life-changing. I slept through the night for the first time. I am not wearing all those pads anymore. I am dry. I can go on car rides. It's really a pretty incredible therapy for patients. And if they like it, then we go to the hospital. And again, a very simple, just under the skin procedure to put this little pacemaker in. And let me go back because I think, okay, so that shows how long it's been around since the 1990s. They got really popular in the past 10 to 15 years. Like I said, it's similar to a cardiac pacemaker. It's made by the same company that makes cardiac pacemakers. We can do it in the office or the hospital. Each stage is, you can just do under local anesthesia, and the batteries last now 15 years, which is nice. So sometimes people need to come in for some tweaking, but lasts for a long period of time. Does this slide say? I think it just says everything that we just talked about. And here, that's the battery pack. So when we're doing the trial, we put that little wire in your back, tape it down, and that's that little battery pack that you don't have that for good. You only have that for the first week while we're testing it. And if it works well, then it goes right underneath your skin. And this slide is just to remind me that to talk about fecal incontinence, because that bladder pacemaker works fabulous as a bowel pacemaker as well. So fecal incontinence is also really common, not as common as bladder issues. It's 1 in 12 of us, but that still makes up 20 million Americans. I mean, it's a very common issue. Patients really feel isolated when they have this. They are embarrassed to go out. They're embarrassed. They smell. They stay home. They really live a life like a hermit a lot of times. It's really hard to get patients to talk about this. If I don't ask, it's really rare people bring it up. And yet this is works fabulous also for fecal incontinence. So I'm not going to go really into fecal incontinence much at this lecture, but just something to know, because a lot of people suffer from both. If you have urinary incontinence, you can also have fecal incontinence. And this slide's just to remind me to talk about, there were a lot of surgeries for fecal incontinence, but they don't work well, don't have nearly the success rate as the bladder and fecal stimulator does. Okay, so lastly, before I turn it over to question and answer, no, actually I have 2 or 3 more slides. Lastly, to talk about overactive bladder, we'll talk about Botox. So as I said, the sacral neuromodulator, or InterStim, works on the nerves. Botox works on the muscle. So if the bladder, here's a picture of the bladder. You can see again, that's that circle over there. The bladder is a muscle. So you can either work on the nerves going to it to get it to relax, or you can work on the muscle itself. So, and Botox works right on the muscle. So Botox is a very quick office procedure. Patients come into the office. The nurse puts a very thin catheter inside your bladder and puts lidocaine jelly so that your bladder's nice and numb. Around 10 minutes later, Dr. Philosophe or I'll come in, and then we put a little injections in your bladder of the Botox, and instead of spasming, it gets it to relax. Again, this is 75% efficacy. I think all the newer data is, much higher than that, more like 85%, similar to the sacral neuromodulators. The good and bad about Botox is it wears off. So people need to come between 6 and 12 months, usually every 9 months for the procedures, just done right in the office. Come on in, get it done, and they're on their way. So, the bad about it is it wears off, but in some ways, the good about it is it wears off because of the 2% of people who can get urinary retention. So, as I said, the muscle is spasming, right? The bladder spasming. We want to get it to relax. Botox relaxes it. Great. But when it comes time to pee, you want to be able to contract that muscle to be able to pee. Sometimes Botox works a little too well, and yes, it's relaxed, but when it's time to pee, you can't empty. So those patients go into retention. And again, it's not common, but when it happens, it's a pain in the neck. And for those patients, we either need to teach them how to catheterize, or we have to keep an indwelling catheter for some amount of time, usually weeks. The most I've had is months. So as I said, the good and bad about Botox is it wears off. So if you were to get that complication, it goes away. But living with it for that short period of time might not be fun, but 98% of patients that doesn't happen with. So it's also a really nice treatment for overactive bladder. All right, so now just a couple of slides on stress incontinence, and then we'll throw this over to question and answer. So that was everything I just talked about, was treatment for the bladder spasms or urge-related issues. Now we're jumping. We're going to talk now about stress-related issues. So that's, to refresh your memory, that's when the urethra or the surrounding structures around the urethra aren't tight enough. So when you cough, sneeze, jump, laugh, you contract, that you push pressure onto your bladder, your urethra is not strong enough, and you leak. So one treatment for that is Kegel exercises. Higher success rates are physical therapy that is, you come in and we actually do the physical therapy with you. We show you on the, we have a little biofeedback to show you to make sure you're using the right muscles to constrict those muscles around your urethra. Another nice thing about physical therapy is it's good for patients who have a little bit of both. So, which is very common. Come in, I have stress incontinence whenever I have a cold and I'm exercising, but also I'm running to the bathroom, I'm going every hour or two. So when you have a little bit of both, physical therapy can treat both. So it's a nice way when patients first come in, either to start and or finish. Sometimes with the physical therapy, we really help the overactive bladder symptoms, but you still have the stress incontinence, or we help the stress and you still have, but we get your bladder in the best shape it can be, and then we kind of move on if we need to other things. So there are a bunch of different surgical and non-surgical ways that we help people with stress incontinence. Old tried and true was a pessary, which is this kind of plastic-like device that people can put in their vagina. You don't have a picture of your vagina right there, but really it's right behind your bladder and urethra. So if you put something in your vagina, it can put pressure on that urethra so you don't pee. Pessaries are a little pain in the neck to put in and out. But for some people, it's easy. They're like plugging it in the morning, taking it out at night, and it puts pressure on their urethra so they don't leak. There was a company that kind of took advantage of this and made, which is kind of cool, these tampons that expand right next to your urethra. So you put it in your vagina, but instead of filling the whole vagina, it fills just right where your urethra is and puts pressure on the urethra. And the brand is Impressa. You can find that in your, when you go to the drugstore, it's like right next to all the incontinence products. It's good for patients who I'm fine unless I'm going to a wedding, then I'm dancing and I'm wet, or I'm fine unless I have a cough or a cold, then I'm leaking all over the place. I mean, most people don't want to wear a tampon the rest of their life, so it's not a great long-term, but it's good, especially in the beginning when it's only at set, set times. There's also things I'm not going to talk about now, like radio frequency and some other devices. I just don't have time in this talk. The tried and true and the treatment that's been around since the 1990s that works very well for stress-related incontinence are slings. And I have a slide on that in a minute, and also some bulking agents. So slings are basically slings. They're a hammock that is put right underneath the urethra so that when you cough and you sneeze, it puts pressure, it kinks that urethra so that you don't leak. It works very well, greater than 90% success rates. It's a very simple procedure. You come in, it's an outpatient procedure done in the hospital. We make a teensy little incision in your vagina, and we thread this little piece of mesh right underneath your urethra. The mesh is small. It's now down to the size of my finger. It's much smaller than it used to be. It's made out of material that we've used for suture forever. So it's a very safe, something that's we've used in the body for a very long time. It goes right under the urethra. And when you cough, sneeze, again, puts this pressure on your urethra, and so you don't leak. This is common. I make the joke that I'll do one person in a running group, and then I wind up doing all their friends, oh, I don't leak anymore, and then all their friends come in because when they're running, they're wearing pads and it stops it. And you're back to, regular activity very quickly. Like all surgeries, it has some risks, but those risks are very small. And if it's something for you, we could talk about that. And then lastly, this is the last slide I have before we go to question and answers, is bulking agents. So bulking agents, a nice way to think about that is most people know about bulking agents now that people are using in their face, like in their lips, to bulk up their lips so that, that they look better. So bulking agents are bulking agents. They're just things that bulk up your urethra. So they've been around for a very long time, but they never were really good until recently. So we use them occasionally. I use them occasionally on patients, with very mild problems, or the sling, it's been 20 years and it's not working as well. There'd be some reasons for using bulking agents. But now it's a lot of times a first line treatment because it's gotten so much better. So a new company came out, Bulkamed, and came out with a much better bulking agent. It's been out in the US since 2020. It's been out in Europe for much longer, many years. I think it's at least 10 years over in Europe. Came out for us during COVID. So for, first year or two, we weren't doing surgery. So we weren't using it as much, but now we're using it much more. Very simple procedure. You inject this little bulking, just like it shows on that camera. You can do it in the office or in the hospital. It's not as effective as a sling. So you have 70 to 80% success instead of that 90+% you see with a sling. But it's really good for people who are risk adverse because there are basically no risks. The only risk is it might not work. And so if it doesn't work, we can always do a sling later. So, I'll talk to patients about both, and you'll have some people who are like, I just want to come in, get a sling. I don't want to have to deal with this again. Complications are low. And other people are like, oh, I don't like to think of any complications. Yeah, let's try this first. So both great options. And again, with each patient, we talk more detail about those treatments. And this is my last slide, which is what we hope to do, which is to put Depends out of business and, help people with other bladder problems. And now I am going to kick this off to Dr. Philosophe for questions and answers. And this has the phone number if anybody would like to call and make appointments. And you're on, Ralph.
I just wanted to add about the slings. When we put the slings in, usually almost always it's a urethra that is what we call hypermobile, where it really drops. And so that's where the sling works very best at. We cannot put slings in urethra that are very well supported. So that's where more we tend to probably go towards bulking agents. But bulking agents have been used for both problems as well. All right, I have to figure out how to get the questions and answers. Let me click on that. Okay. Can you see that, Barbara?
I don't see the